This is Dr. Howard Strassler presenting the e-lecture, Pulpal Protection, Bases, Liners, Sealers, Caries Control, Clinical Applications, where we're going to be looking at how we use these bases and liners and sealers, as well as we'll be looking at how to mix them and apply them to the tooth preparation. First of all, there are certain guidelines when basing, lining, or sealing, and the best base is always the tooth structure itself, conserving the tooth structure. And so we try to follow these basic rules. Do not remove healthy or sound tooth structure to provide space for a base. We're going to use a base to build up and block out for cemented restorations, to provide thermal insulation, to provide a dentin substitute. If we're using a base for amalgam or composite, minimize the amount of base that you use, and you always want to try to maintain that the restorative material sits on dentin and enamel somewhere. You don't want the base to support the entire restoration. And in the United States, we don't base a preparation to create an ideal depth. This is contraindicated and can lead to an increased risk of restoration fracture. The base materials we use are not as strong as, don't have as good of physical properties as the composite and amalgam that we use. When we're applying liners, when we're sealing, liners should be applied with a minimal thickness, half a millimeter or less. We want to use a minimal amount of liner to achieve a result. We don't want to cover everything with a liner. Calcium hydroxide should only be placed where needed, adjacent to the pulp. We're not going to cover an entire wall, but just isolated areas where we're adjacent to the pulp or when we're pulp capping. Currently, the primary use of adhesive with amalgam is for retention as a replacement to invasive pins or groove slots or mal pins. And in fact, the studies show us that adhesive amalgams are as retentive as those that have pins that are placed, extra grooves or slots. So let's look at the recommendations for liners, sealers, bases for different types of depth cavity preparations. And we're first going to look at amalgam. For a shallow cavity preparation, we're only going to use a sealer, typically a cavity varnish, and then the placement of amalgam. Those are preparations half a millimeter into the dentin. For moderate cavity depths, those that are within 1 to 2 millimeters of the pulp itself, and we note that by a radiograph, we place a glass ionomer liner, Vitribond, then our sealer, our cavity varnish, and then amalgam. For deep cavity preparations, we're going to use calcium hydroxide in isolated deep areas of the cavity preparation, covered completely as a liner, the glass ionomer, followed by our barrier cavity varnish, and then our amalgam. We never use Optibond Solo Plus with amalgam. We never use Xeno 4 with amalgam. If we're placing a sealer, we're going to use our cavity varnish. For composite, there are similarities. For a shallow cavity preparation barely into dentin or still in enamel in a pulpal depth, we're going to use our adhesive. We're either using our Optibond Solo or our Scotchbond Multipurpose or our Xeno 4. And then we're placing our composite resin. For moderate depth cavity preparations, we're going to be using a glass ionomer of liner, our Vitribond, followed by our bonding agent, and then our composite resin. There are some who feel that for moderate depth cavity preparations, 1 to 2 millimeters from the pulp, that placing only an adhesive bonding agent is adequate. And I think you'll see some changes, the move to using bonding agents only for moderate depth cavity preparations. For deep cavity preparations within a millimeter or less to the pulp, we're going to use our calcium hydroxide in isolated areas, followed by our glass ionomer, our Vitribond, then our adhesive, our 4th or 5th generation adhesive, or our self-etch adhesive, and then our composite resin. Now, when we look at resin adhesive bonding agents with composites, and here you're looking at a radiograph of a composite placed, an MOD, and what I'd like you to notice is that on the left-hand side, I see radiolucent areas. The arrows are pointing to these radiolucent areas. If I look on the right-hand side, the composite is well adapted to the cable surface margin and the cavity preparation. There's been some concern recently that when placing a composite, especially a posterior composite, that the adhesive would pool in the proximal box at the gingival margin, and that when we light cure it, we end up with a thickness of the adhesive. And in fact, the adhesive mimics recurrent caries. This is a very controversial area. In fact, many dentists, if they saw the image on the left-hand side, would be replacing that restoration. If you place the restoration is not that old, has only been in place for a year or so, and you have sequential radiographs that show that there are no changes occurring, then one can assume, using your Explorer to see whether or not there's a gap, that this is adhesive. We'll see how this issue plays itself out. When we place liners and bases in cavity preparations, there are different radiopacities when compared to amalgam and composites. In fact, in these X-rays of extracted teeth, where deep bases have been placed with flowable composite, you can see flowable composites have different radiolucencies. So we need to know the restorative materials that are placed beneath our composites and our amalgams, so that we don't misdiagnose recurrent caries. So let's talk about amalgam and composite as it relates to material chemical compatibility. When we talk about amalgam, we know that cavity varnishes, barrier, are chemically compatible with the amalgam. That if we're using Scotch-Bond Multipurpose, the 4th generation resin adhesive, etch and rinse, and we use it as a self-cure, we can use it as a bonding agent for the amalgam. Calcium hydroxide dical is chemically compatible with amalgam, as is Vitribond, our resin-modified glass ionomer. If we're placing cavity bases that are thicker than liners, we can use our Vitribond, our Fuji 2LC, our Fuji 9, and typically what we might be using, leaving it as a base, is if we're using Fuji 2LC or Fuji 9 for caries control or temporary restoration, when we're preparing out that temporary restoration, we can leave these materials in as bases and liners. We don't have to go back to our Vitribond. Let's look at dispensing and application of cavity varnish with use for amalgam. First of all, barrier, the Dentin sealant, our cavity varnish, is applied as a liquid in a bottle. They provide little pipettes where we can pipette the barrier into the tooth preparation, although I typically use a disposable brush dipping it into the bottle. I apply it to the tooth preparation, no double dipping, and then I dry it with a stream of air, and then I place my amalgam. When I dry it with the stream of air, I'm also thinning out the barrier so it's not too thick, it's not pooling within the cavity preparation. And so we say no double dipping. And here we're looking at the dispensing of barrier using a disposable brush, and then we'll place this in the cavity preparation. We won't go back and dip into the bottle again once we've gone in the tooth, because that would cross-contaminate the bottle. So let's take a look at placement of the barrier varnish for use with amalgam. This preparation has had calcium hydroxide, dical, and resin-modified glass ionomer Vitribond already placed previously. We'll see those placements in some videos later on in this lecture. So let's take a look at the application of the barrier. We're going to dip our disposable brush into the bottle, and then we'll take that brush and apply that liquid into the cavity preparation. And the reason for using a disposable brush is it will have sufficient liquid to apply to large cavity preparations. I then take my air stream and I air thin out and dry and evaporate the solvent from the barrier. And now I'd be ready to place my amalgam restoration. Composites give us a little bit of a challenge. We never use barrier with composite. It's not chemically compatible. We never use IRM. IRM is a reinforced zinc oxide and eugenol. We don't want to use eugenol containing materials with composite resins, with resin adhesives. Our cavity sealer for composites are our resin bonding agents, our Scotch-Bond multipurpose or our Optibond Solo. Calcium hydroxide dical and resin modified glass ionomers Vitribond are chemically compatible with composite, as are our resin modified glass ionomer restoratives Fuji 2LC and Fuji 9, where we may have done caries control or a temporary restoration with the glass ionomer restorative, and we're now preparing it out, leaving it as a liner or base, and then restoring it with a composite. We can do that because the glass ionomers are chemically compatible. Let's talk about using a resin adhesive for amalgam bonding or for dual cure composites. A dual cure composite would be a composite core material like our Fluorocore 2+, or our self-cure composites. The Scotch-Bond multi-purpose kit contains components that we can use for amalgam sealing and retention. We can also use it as a dual cure system for composites, like our composite core Fluorocore. We can use it for amalgam bonding to give us additional retention beyond our preparation form. We can use it as a substitute for pins, slots, and grooves. So let's talk about using Scotch-Bond multipurpose for use with amalgam or for dual cure or self-cure composite resins. We're going to etch the tooth for 15 seconds, rinse it for 10 seconds, and dry the tooth off. We're going to mix the activator and the primer in a disposable Dappen dish, 1 drop each. We're going to mix it using our disposable brush, and we're going to apply it to the etched preparation for 15 seconds. We're going to gently dry it from the preparation for 5 seconds. We're then going to take the catalyst and the resin adhesive from the Scotch-Bond multipurpose, 1 drop each, mixing it in a disposable Dappen dish with a brush, disposable brush. We're going to then paint it in the preparation. We're not going to light cure. We're going to gently air thin. We're then going to place our amalgam immediately into the preparation, or immediately place our dual cure resin cement or our dual cure Fluorocore composite core material. When it's time for you to use this material, I'd recommend that you refer back to this section. In fact, when you get into the clinics, I'll be sending a hints from Howard that you can keep as a reference for the use of this material for amalgam bonding and for the cementation using dual cure composite resin cements. When we're using these adhesives, resin adhesives with composite, we're going to use the technique, and you've learned this in the first year, and this is a review of it. We're going to be etching the enamel and dentin simultaneously for 15 seconds, rinsing for 10 seconds, then drying the tooth off. We'll then be applying our adhesive, whether it be a single component adhesive, which would be our Optibond Solo Plus, our multi-bottle system, which would be our Scotch-Bond multipurpose, applying the primer first for 5 seconds, then air drying it, and then applying our adhesive and air thinning it, or a self-etching adhesive where we're not going to be etching with phosphoric acid. The self-etching adhesive will etch the enamel and dentin. And then we apply using our composite resin, using the compules of composite resin with the shade we selected, using the compule gun, compule applicator. We talked about etch and rinse materials. The Scotch-Bond multipurpose is a multi-bottle 5th generation material, separate primer, separate adhesive, as compared to our single component Scotch-Bond multipurpose is a 4th generation material. Optibond Solo is a 5th generation. It's incorrect in these slides, and I'll correct this in the presentation you'll be getting downloading. Optibond Solo is a 5th generation single component primer and adhesive in the same bottle. The purpose of the adhesive of the bonding system is to seal the tooth in the restorative interface. It decreases the leakage at the tooth restorative interface. It enhances restoration retention by mechanical locking of the adhesive to the roughened surface. In fact, if we look at the images on our left-hand side, you can see what etched dentin looks like, where the tubules are opened up, and the peritubular dentin looks like a sponge. The enamel surface on the lower left looks like carpeting. We then apply the resin adhesive to the dentin and the enamel, and when we light cure this adhesive, it seals the enamel and dentin interface. The resin infiltrates the dentinal tubules, and we create a hybrid zone within the peritubular dentin. And so what we're seeing is, through our tooth preparation, we create a dentin smear layer, where we have this loosely bound conglomerate of dentinal chips and different materials, creating a smear plug that when we etch, this loosely bound debris of collagen and hydroxyapatite crystals is removed through the etching process. With a self-etch adhesive, in fact, this dentin smear layer is dissolved and it incorporates itself in the adhesive itself. So we're etching tooth surfaces. On the left-hand side, we're looking at the smear layer of the enamel and dentin. We apply a phosphoric acid etchant, generally in the 30 to 35% range of phosphoric acid, applying it to the tooth for 15 seconds. We rinse it for 10 seconds from the tooth and dry, and when we dry, it leaves the etched dentin and the etched enamel. We rinse the etchant from the tooth for 10 seconds with an air water spray, and we then dry the tooth off. The etched surface of the tooth has a frosty appearance. The dentin should be slightly glossy. We don't want any visible water on the surface of the enamel or dentin. Applying our adhesive, and here we're talking about a single component adhesive, the Optibond Solo, that for class 3, we're placing a mylar strip in between the teeth supported by a wedge. We apply the matrix and wedge, then we paint in the single component adhesive with a brush or a micro brush. We rub it into the dentin surface and allow it to sit on the dentin surface for 5 seconds. We use a gentle airstream over the adhesive, which evaporates the solvent. It slightly thins the adhesive layer, and then we light cure the adhesive. Once the adhesive is light cured, it will be wet, and that's the air inhibited layer, and this is an important layer for bonding between the composite and the adhesive. And this is a review of something that you learned in the first year. When we're applying a multi-bottle adhesive, a 4th generation adhesive, the Scotch-Bond Multipurpose, the primer is a hydrophilic primer, meaning that it likes a moist surface. The dentin is slightly moist. The enamel should be dry and frosty in appearance. We apply the primer to the dentin and the etched enamel. We air evaporate it off after 5 seconds. We then apply our adhesive. If you notice, the primer is clear in color. The adhesive is sort of yellow-orange in color. That yellow-orange color is, in fact, the photoinitiator colors it, the camphoraquinone, the CQ, and when we light cure, it bleaches out that orange-yellow color. We apply the adhesive to the enamel and dentin. We air thin it and evaporate off the solvent, and we then light cure for 10 to 20 seconds. The chemistry of etch and rinse adhesives, total etch adhesives, for the multi-bottle 4th generation adhesive, it's an organic solvent with a hydrophilic monomer, which is HEMA, which is hydroxyethyl methacrylate. The adhesive is a bis GMA resin with HEMA in it as well, with hydrophilic monomer. Our single component etch and rinse adhesive, our Optibond Solo, is a 5th generation where the primer and the adhesive are in one liquid, so that we have an organic solvent typically alcohol, although it could be acetone, a hydrophilic monomer, or HEMA, or hydroxyethyl methacrylate, and a bis-GMA resin, and a very small quantity of water. Our bonding procedure is a simultaneous etch of the enamel and dentin for 15 seconds, where we apply the etchant to the enamel first. We then rinse and dry the etchant out of the tooth, apply our adhesive to the etched enamel and dentin surfaces, evaporate off the solvent, and then we light cure for 10 to 20 seconds with the light at right angles and as close to the tooth structure as possible. Let's now talk about calcium hydroxide, dispensing and mixing the calcium hydroxide and applying it to the tooth. First of all, calcium hydroxide is supplied as 2 tubes, a base and a catalyst, and it's dispensed as 2 equal portions of paste onto a mixing pad. We're going to mix those 2 pastes thoroughly together for 10 seconds using a cement spatula, and then using a base placement instrument, we're going to place it in the tooth preparation. And the base placement instrument is a ball-ended instrument that allows for precise placement. For larger increments of dical of calcium hydroxide, we can use our amalgam condenser to apply it to the cavity preparation to pulpal walls and axial walls. To accelerate the set of dical, we can place a moist cotton pellet in the cavity preparation for 15 seconds, remove, and then continue with the next step. Calcium hydroxide dical is a self-setting, a self-curing, self-setting material, and the moisture of a cotton pellet, not a wet cotton pellet but just a damp one, is enough to initiate the setting reaction. Keep in mind, our preparation's isolated with a dental dam, and there isn't a lot of moisture available. Let's take a look at mixing calcium hydroxide. We're going to squeeze out of the tube equal amounts of base and catalyst. We're going to put the correct tops on each tube again. I'm going to take a cement spatula and thoroughly mix the dical together for 10 seconds. Okay. Dical is always covered with Vitribond. So here we're looking at calcium hydroxide applied in the cavity preparation, and we're going to cover this with Vitribond. Let's now look at dispensing and mixing materials. We're looking at the resin-modified glass ionomer Vitribond. We're going to dispense 1 drop of liquid and 1 scoop of powder onto a paper mixing pad. The powder is going to be dispensed using the dispensing spoon, the dispensing measure that comes with the Vitribond. We're going to mix the powder and liquid together thoroughly for 10 seconds, and then we're going to apply it to the preparation using our base placement instrument. After placement, we're going to light cure for 20 seconds and continue to the next step. The reason we're light curing for 20 seconds is that these are deep areas of the cavity preparation, and the light, the energy of the light, the irradiance of the light needs to travel a long distance. It may be traveling 3, 4, 5 millimeters, and so we need additional curing time to photoinitiate the glass ionomer. If we didn't light cure the glass ionomer, it would self-set in 5 to 7 minutes. Let's take a look at mixing the Vitribond as a liner and base. We're going to dispense with the measure that comes with the bottle, 1 scoop of powder, and we're going to dispense 1 drop of liquid. We're then going to take a clean cement spatula and incorporate and mix the powder and liquid together completely. We want to thoroughly and totally wet all powder with the liquid. Make sure you incorporate all the powder. It may take longer than 10 seconds. Once we've applied the Vitribond, we can then pick it up using our base placement instrument. So let's take a look at placement of the Vitribond. The calcium hydroxide has already been placed in the cavity preparation using the base placement instrument. And now we're going to layer in the Vitribond into the cavity preparation. And the reason we're layering it in, is we want to cover it completely. Any excess glass ionomer, like we've gotten on this lateral wall, once we've light cured, we're going to go back and prepare that surface. Here we have a deep proximal cavity preparation, so we're applying it to the axial walls. And once again, excess, once light cured, will be removed using a round burr. We then light cure the preparation for 20 seconds, and then we can go on to the next application. We can apply our matrix band and our cavity varnish. We're going to remove the excess glass ionomer that's at our cavo surface margins and on our cavity walls using a slow speed with a round burr. Vitribond should only be on internal cavity walls. After light curing, remove the excess Vitribond from any undesirable cavity walls, buccal and lingual cavo surface margins. We'll do that with a slow speed handpiece with a round burr to remove the excess Vitribond. Vitribond should never be on cavo surface margins. All the cavo surface margins should be tooth structure. For this case, we're going to place barrier to cover the Vitribond. And so we're going to dispense the barrier from our bottle. Okay, no double dipping. We're going to then go to our cavity preparation. We have our matrix in place and our wedges, and we're placing our cavity varnish into the cavity preparation. We then air thin it, and now we're ready to place our amalgam restoration. Let's take a look at some clinical cases. What application do we do to do deep cavity preparations? Our classification, our diagnosis for number 8 and 9 are class 5 caries. In fact, number 7 has already been restored with composite. You can see the white spot lesion on the facial surface of number 10. We've done our cavity preparation, and all the caries is removed, and we're very close to the pulp. We're going to place calcium hydroxide in the central area just as a very small isolated placement, and then we're going to cover the DiCal with Vitribond. Notice the 212 clamp in place, isolating this anterior tooth. The enamel surfaces have been beveled, and now we're ready to do our adhesive composite technique. Or for this occlusal preparation, which is moderate depth, the caries has been removed. Our pulpal depth is a little over 3 millimeters. We place our Vitribond into the cavity preparation, and then we light cure for 20 seconds. We're going to be placing amalgam, and placing amalgam will then go in and place our cavity varnish barrier. If we were placing composite, at this point we'd etch the tooth, and then place our adhesive, air thin, light cure, and then place our composite. Here we're looking at a deep axial wall where we're placing our Vitribond on the axial wall, and we're light curing that Vitribond on the occlusal surface where the light is actually touching the cusp tips. We're centered over the proximal box, and we're light curing for 20 seconds. Here we're going to be using, on this very deep axial wall in the distal, we're going to place some DiCal, and we're going to cover that with Vitribond, and then we'll place our matrix and restore it with either amalgam or composite following the appropriate sealer technique. Let's look at the radiographic appearance of liners and bases. On the left-hand side, we can see an amalgam restoration that's been placed, and you can see a glass ionomer Vitribond liner that's been placed on a deep axial wall. Notice it's about the same radiopacity as Denton. On the right-hand side, we can see a deep cavity preparation where a base has been placed. It's a glass ionomer base that's been placed in the cavity preparation, and you can see it has a very different appearance than that of the amalgam, which is very white and radiopaque. You've been listening to and viewing Pulpal Protection Bases, Liners, Sealers, and Caries Control, clinical applications of these materials.